Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a hard cataract. Nuclear sclerosis in this case is about grade 4. Let us observe this surgery. This is the main incision with a 2.8 mm steel keratome on the posterior aspect of the limbus at 135-degree axis. And now this is a side port on the right side of the main incision, 3 clock hours away. This is another side port on the left side of the main incision, same distance away. When the side ports are 90-degree away from the main incision, astigmatism induced by the main incision is neutralized to some extent by the side ports. The anterior capsule has been stained underneath an air bubble with trypan blue dye. Few drops of adrenaline has been injected into the anterior chamber. Now the dye is washed out, and now 2% hydroxypropyl methyl cellulose is being used to fill up the anterior chamber. And now we are going to do capsulorhexis. The anticapsule is torn and a capsular tag is raised by the tip of the ureter forceps, and the tag is then guided anticlockwise, remaining at a certain distance away from the margin of the dilated pupil, and an adequate sized large round rhexis is obtained by the ureter forceps. And now hydrodissection. Small amounts of fluid is injected at multiple points and the nucleus is mobilized. 2% HPMC is injected again, and now is the time to introduce the tip of the phaconeedle. The machine being used is Ophth Cataract 3. This is a totally unedited surgery. You are watching each and every step of the surgery. The phaconeedle goes bevel down. Some superficial cortical lens matter is removed. And now the handpiece is turned with the help of the left hand. And now watch the submarine chop. The nucleus is pushed little down and the tip goes into the substance of the nucleus just in front of the main incision, travels through the nucleus towards the opposite equator, and as it reaches near the opposite equator, the chopper is used to chop the nucleus, and by lateral separation a nice crack is obtained. 180-degree rotation and the nucleus has been separated completely into two heminuclei. Each heminucleus is then subdivided into two smaller fragments, and now we have got 4 free large fragments. Each fragment is tilted and emulsification is started from its apex. Always keep the tip of the phaconeedle at the central part, central 3 mm safe zone. If we tilt the nucleus and start emulsifying from the apex, the blunt equatorial part rests on the capsule and there is no chance of posterior capsular rent by the sharp hard apex of the large fragments. And this is the last nuclear fragment. In this case, after emulsifying half of this fragment, I'm going to reduce the parameters. From here, I'm asked to go to phaco on mode. Yes, from here I ask my assistant to go to phaco on mode, where the vacuum is only 60 millimeter of mercury, flow rate is 25 ml per minute, and vacuum is 70%. And very safely the last bit of nucleus has been emulsified. This is a bit of his PMC. By the time my assistant gets ready with bimanual irrigation aspiration, I remove the cortex from the left side so that I will not require to change hands. Irrigation will go through the right side port, and all the cortex from the right will be aspirated going through the left. Here it is. The irrigating probe of bimanual IA goes through the right side port, aspirating probe from the left, and here it is. The cortex from the right side is removed. There was very little cortex. Whatever was there has been removed. The posterior capsule is clean, no cells at all. And now the main wound is being enlarged little bit because I'm going to use a thick whiteboard cartridge. If we don't enlarge the main wound can get stressed, there can be fish mouthing, and chance of leakage becomes more. In this case, the lens didn't go into the capsular bag. Here the trailing haptic has gone into the capsular bag, and now the lens is rotated, and here by a push of the irrigating probe, the leading haptic has gone into the capsular bag. The lens is dialed, and it is done. Whatever visco was there in the lumen of the cutis has come out. This is a bit of moxifloxacin, and now the side ports are closed by hydrating corneal stroma on either side of the stab wounds. And now this is the final lavage of the anterior chamber. So it is done. The antechamber is formed very nicely so that the intraocular pressure is on the higher side of the normal. Integrity of the wounds are checked. Few drops of moxie is applied over the cornea, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon. Increase your skills every day. Serve your patients with love, respect, empathy, and great surgical competence.